Hello, and a very good afternoon, everyone. Welcome to the Independence Age briefing. My name is Goody Singh, and I'm going to be your chair for this briefing. Today, we're going to be having a very important discussion on creating safe spaces and environments. Now, as COVID continues to spread, we want to reiterate that the pandemic is far from over. The burden of widespread infection and reinfection is real, as research into long COVID continues to point out. We are now discovering that there may in fact be more long COVID symptoms than previously known. Given this, it is all the more important to take precautions to minimize chances of getting COVID in the first place. But the lack of proper mitigations in the form of government directives makes this a difficult task. We can, nonetheless, take some steps for our own safety. So today, we're going to look at how to create safe environments around us and also navigate spaces that are of high risk. For this, we have three guests with us today. First, Dr. David Tomlinson, then Lara Wong, and then Dr. Lena Sirik, who is not with us in person today, but who did provide a pre-interview, which we will play in due course. Now, before we go into our main session, I'd first like to invite Professor Christina Pagel to share with us the latest COVID numbers and trends. Over to you, Christina.
Hi. Okay, so it's going to be quite quick today, I hope. Just going to cover the latest data on hospitals and deaths and prevalence in that order, and hopefully you'll see why. And then just very quick update on the data that's come out this week on sickness absence in hospitals and education. And then just a couple of things about long COVID that came out this week as well. So first on hospitals, this is the number of people in hospital with COVID per million people in each UK nation. You can see in everywhere this has peaked about a week or two ago. So that is good news. And the numbers of people in hospital with COVID is coming down. And it reached higher than the first Omicron wave and lower than the second one, basically. Here you can see hospital admissions in England. And again, we're seeing nice steady drops now. So I think it's pretty clear that this wave has peaked and is coming down. In terms of deaths, however, they are lagged. So, it takes people who die, it's a few weeks from infection, and also registration with the Office of Statistics takes a bit longer. So we see that typically quite a bit later than we see data on infections in hospitals. And you can see that deaths are still going up. So just over 500 in the last week in England and Wales. This is lower than the previous 2 weeks, and this could well be because of the spring booster campaign. We see the similar pattern in Scotland, where it looks like deaths are just peaking this way. And in Northern Ireland, they've been going up as well. But as we saw from the prevalence data, Northern Ireland kind of hasn't had three distinct waves. It had one big wave for about 2 months over the winter, and then another wave now. And we'll see that really clearly in this prevalence chart. So this is from the Office of National Statistics Infection Survey, which is based on random testing. Each of the nations, so this is the big January wave that we had in Scotland, Wales, and England. That's the March-April wave we had in those three countries. And this is the current BA5 wave. And you can see that England, Scotland, and Wales have all peaked. It's less clear what's happening in Northern Ireland. And again, Northern Ireland had this kind of weird, 2-3 months where the BA1 and BA2 waves kind of merged together. But nonetheless, the prevalence of COVID still remains very high. Everywhere, don't think that you're not at risk. We're still very, very far away from the levels we got to in the spring and where we were last summer, which is still high prevalence. The good news in England is that we're seeing drops in all age groups and pretty much over all regions as well. So this is really quite a uniform drop. So that's encouraging. And it's not a surprise, right? This wave wasn't a surprise. I think, people can say, oh, I didn't know. And how did we not know? Well, we did know. So these are just 2 tweets that I did back in May when we first saw kind of BA4, BA5 and BA2.12.1 all growing against a background of BA2. And at that point, me and lots of other people as well were saying, look, if this keeps growing, we're going to get a new wave in a couple of months. And here, even towards the end of May, I was saying it would be the end of June, early July, and that's exactly what we've seen. So it's not a surprise that we can see these things coming, and we can also do things about them. At the moment, this is just data from the COVID Genomics Consortium. The share of sequences that reach variant is mostly kind of BA5 and its subvariants. But unfortunately, what we're seeing is a growth of lots of sequences that are down as unassigned. And this makes it really hard to interpret. You can't really see what's happening. This is likely due to the fact that at the moment, Omicron is just shooting off subvariants everywhere. It's actually really hard to do the assignment. And also there are now fewer resources at COG devoted to COVID. They're doing other things. So that's also kind of making it tricky to kind of keep track of surveillance. And that's something that I think we should be a bit worried about as we go into winter, is that our surveillance is getting a little bit weaker. When it comes to impact on sickness absence in schools and the NHS, the latest schools data came out. This is pupils in all state schools in England for any reason. But you can see, like, in the last week, really, it was 19% of all students were off for some reason. I mean, that's really, really, really high number, and it excludes people off on study leave, so that's not affected by GCSE and A levels, and it's far, far higher than the average that we had in 2018-19 before COVID. So just saying that yes, schools are open and we don't have any restrictions, but it's not actually bringing children into school in the same way that it did pre-pandemic. In teachers, absence remains quite high, but actually it's fallen in the most recent week. And this is kind of similar to what we've seen in this wave, that actually the first age groups to get infected were younger adults, and children came a week or two later. And I think that's reflected in this sickness data. The NHS England staff sickness data, now this is, they've come out of winter reporting, so it only reports every month and it only goes up to a few months lagged. So we only have data up to March 2022. So that's the March peak, March-April peak, not this current one. But you can see here again that staff sickness was going up. This is all absences, so any reason. If we look just at COVID absences, though, you can see very clearly how every way does impact quite severely the NHS staffing and the ability to have people in work. And when we look at it by reason, so these are all different reasons, the top 6 reasons for absence from work, they're all reasonably stable, but here these two you can clearly see are the spikes is corresponding to respiratory, flu, infectious diseases, and this will primarily be COVID that's driving those rises. So just on long COVID, so there's the Institute of Fiscal Studies that I want to show, and also 2 papers that came out this week about long COVID. So the Institute for Fiscal Studies was looking at kind of people's economy, the economy and how people work. And it's a lot, and it uses not the ONS data, but it uses its own data, which is kind of a long-standing survey of people in and out of employment. And they just released their previous briefing. And this is just comparing people who report having long COVID and people without long COVID. And it confirms the ONS survey and many other studies showing that actually the most common age groups for this is kind of middle-aged adults, so people in the prime of their working life. You can see they're much higher in with the long COVID than without long COVID. And also confirming what we've seen in other studies showing that if you have some kind of long-term health condition, you're more likely to have long COVID. And if you're poor or disadvantaged, you're also more likely to develop long COVID, which is partly probably because you're in worse health, but also because you're more exposed to catching it. But this is kind of the meat of their report, where they were looking at what impact has it had on people's working patterns. So they looked at what was the average before the pandemic, and then what is it now if you have long COVID. And they showed that looking at whether you're working at all, there's been a 6% reduction in people. The hours you've worked, your working has gone down and your earnings have gone down. So basically what they're saying is that on average, people are losing about £1.5 billion a year by not being able to work because of long COVID, and it's equivalent to over 100,000 workers being off sick any one time. So it is kind of a substantial impact on the economy. This is a new paper that came out using the UK GP database, and they looked at GP records of 486,000 people with confirmed COVID but who weren't hospitalised, and looked to see whether they see what their visits were like over the following period, and they matched that to about 2 million people who didn't have confirmed COVID. And they kind of found 62 symptoms that were significantly associated with after COVID, right? Of people who significantly went to the GP more with that than people who didn't have COVID. And they fell into these kind of 3 clusters, where class 1 was the biggest, and that's kind of very general type symptoms, then something that's very much based around coughing and shortness of breath, and then something around anxiety and depression. There are limitations to the study. It depends on people going to their GP with problems. It depends on the GPs recording them. There's also a lot of people who haven't got confirmed COVID who will have had COVID. So there are limitations, but it is yet another study adding to the evidence we already have that there is a wide and long-lasting impact that COVID can have. There's also a new paper that came out in the BMJ looking at people who'd lost their taste and smell, where they combined 18 studies looking at 3,700 patients overall. And basically they said, if you lost your taste and smell, about 3/4 of people recovered it within a month, and almost everybody within 180 days. But about 5% have long lasting, so more than 6 months, loss of either taste or smell. And so what they're saying is that given how many people had this happen to them, there are millions of people in the world who have this kind of ongoing loss of taste and smell, and for some it's completely debilitating, and that this is a big issue. So just the caveat here is that this is largely data from the pre-vaccination era and also pre-Omicron, which is less associated with smell and taste problems. So just to summarize, the BA.5 wave has now peaked across the UK, and cases and hospital admissions are falling reasonably rapidly, which is good news. Deaths are lagged and still increasing, but they should start to fall again soon, lower than previous peaks, which is probably spring booster effect. The NHS does remain under extreme pressure, and staff off sick adds to that pressure. We haven't yet seen the staff sickness data for the most recent wave. Sickness absence has been increasing rapidly in schools, but thankfully now it's the school holidays. So, and next week, actually, we're going to be focusing directly on schools and a call to make schools safer for the next term, because we can see that there is this kind of issue in a lot of children staying off sick. And there's more and more evidence from different perspectives about the clinical, personal, and economic impact of long COVID. And again, to prevent long COVID, we're really going to have to look at preventing transmission. And with that, I will stop.
Brilliant. Thank you so much, Christina, for your great presentation. And we're thankful, as always, for all of your insights. We now move to the main discussion, which will be hosted by Professor Trish Greenhalgh and Professor Susan Michie. Over to you, Trish.
Right, thanks very much, Goody. And I've just got a few slides to show. Myself and Susan will be welcoming our 3 guests, which Goody has already briefly introduced, and we're going to be talking about towards safer environments. And as as Christina has said, next week this kind of continues, because we're going to be talking specifically next week about safe schools. But let's just get warmed up for this and remind ourselves how the SARS-CoV-2 virus travels. Most of you know by now that it is an airborne virus, and you can see in this enclosed space, this picture of a room, person on the left has got COVID and is coughing and breathing and panting, and some of the droplets with the virus in are falling to the ground quite quickly within 2 meters, but actually some of the micro droplets are suspended in the air and they're floating right through all through the space in this case a room, and that actually is what underpins what I'm going to say in the rest of this presentation about how we're going to make our environments safe. You've got people indoors breathing the virus out, the virus spreads within the space available, and the more people that are there and the higher the prevalence of COVID, the more virus there is to be breathed in. It's no accident then that the SARS-CoV-2 virus was first isolated from air in very small enclosed spaces. The first isolation of the virus was from a car of an infected man, I think, or a hospital side room where there were 2 people in quite a small room. And then there's some animal studies where you've got the animals in a cage and it's all sort of wrapped up. And again, little animals panting away, and the virus is quite easy to isolate because there's so much of it. So bearing that in mind, if you wanted to catch COVID, how could you make things really bad for yourself? And the answer is you'd go indoors with a lot of people and spend a long time indoors, because the longer you're breathing in and out that contaminated air, the more likely you are to get COVID, particularly if the ventilation is poor, particularly if there's a lot of people in that space and the space is small volume. One thing you could do to make it even worse is get everybody panting away, get in a gym, or get people singing or shouting. And finally, make sure nobody's wearing a mask. So that's what you want to do if you want to catch COVID. If you don't want to catch COVID, and that's what we're talking about today, spend as much time as possible out of doors. It's not completely safe, but it's about 20 times safer than being indoors. And if you can't do what you want to do out of doors, find a really large volume space. A cathedral is great because it's almost like being out of doors because the ceilings are so high and there's lots of ventilation there. It's always quite drafty in cathedrals, isn't it? But if you can't find a cathedral, you need to make sure that you're avoiding crowded indoor spaces and particularly close contact. And that's partly because the large droplets spread between people who are close to each other, but it's also because the airborne spread is worse the closer you are to somebody. That's just basic physics. If you're in charge of a building, make sure it's well ventilated or that the air's filtered, and we'll come on to that in more detail in just a second. And if you're indoors with a lot of people, the best thing to do is stay quiet and don't do too much physical exercise. I've given you a yoga picture there, that kind of thing. And finally, of course, really important, make sure everyone's wearing a mask, that it's fitting well, and preferably that it's one of those high filtration masks known as a respirator. So now my technology has failed. There we are. I'm going to hand over to Susan to introduce our first guest.
Thank you very much, Trish. And what we all know is that a lot of the social life that we want to be engaged with doesn't meet the criteria of COVID safe spaces that Trish has outlined. Cinemas, theatres, pubs, restaurants, a lot of them are smaller enclosed spaces. And for many people, that is a very risky situation to be in. And so I'm really delighted that we have Lara Wong with us today. Lara, welcome, who's from the organisation called Clinically Vulnerable Families. And I wanted to start off, Lara, by just asking you, what's life like for clinically vulnerable people now at the moment?
Okay, so we kind of have to break that question down a little bit, because obviously we know that there's a range of vulnerabilities that people are experiencing. So, we have people who have low or no immunity following up to 5 vaccinations. And they're essentially, they may well be at the very start of the pandemic. So if they are to be infected, then, they're at really, really high risk. We have other people who have received vaccinations, but also, again, there are concerns. So, if you think about that CEV group, they were last vaccinated last September. So their vaccines are now waning. And they weren't necessarily, unless they were severely immunosuppressed, included in the recent round of vaccinations. So those people are quite concerned as well, and even, the clinically vulnerable, which would be the lower kind of group, but they're still high risk and we're still seeing deaths. And if you look at the deaths of, for example, the diabetics, they still, are a fair proportion of our overall deaths. So, we have to be concerned for the entire community, because our clinical vulnerabilities are not going away. And so we need to be aware of our risks. And so each person has to assess their risk for their activity and circumstances. But it's really difficult right now because we don't really have accurate data to make decisions on. And it's a very difficult task for people to do on an individual basis, to make those decisions. So yes, antiviral access as well, another concern. We're finding that some people are not receiving them, even though they are on a very restricted list. when it gets to the point, maybe they're over the 5-day mark, or maybe they're being told that they should not be receiving it even though they are on the list. It's very difficult for them to sort of argue at that point. And so,
yeah, and I think your point about not having the information to make an informed choice is a really important one, because if places aren't going to be made
difficult, it is
safe,
it is.
universally safe. Can I just go on to ask you what kinds of places you're most worried about visiting?
So I can't hear you.
So what kinds of places are you most worried about visiting?
Okay, I still can't hear you, but I'm going to carry on. So I'll answer the next question. If you can you hear me?
I can hear you. Can
okay,
other people hear me?
Yeah, magic. Okay, brilliant. Okay, so in terms of places that we're concerned about, you can see on this slide, the number one place that we're really, really concerned about right now is healthcare. And you're probably aware that lots of healthcare settings were told that they should be removing masks, and that put a huge pressure on our group, because when you're looking at the clinically vulnerable community, they are a group of people who will need more medical treatments. It's the elderly as well also will need more medical attention, and so removing the masks in those high risk places where, as you said, people are more likely to probably be infected, and enclosed spaces and ventilation isn't great. It's really worrying, because the only thing we have to rely upon in those circumstances really is our mask. And whilst we can buy better masks, that's about all we can do. And sometimes they tell us to take off those better masks and put on the lower grade masks, which
very annoying.
It really is.
So in terms of things that would make you feel safer, you talked about information about what the air quality is like,
yes,
in terms of indoor spaces. You talked about masks. Anything else that would be helpful from your perspective?
Okay, so I mean, obviously, we want all the things that you guys talk about week in, week out. We want to see, the HEPA filtration, which is really cheap. If you look at the cost of a member of staff that's going to be missing a day or a week or 2 weeks if they're infected with COVID, or even longer if they've got long COVID, it seems like a real false economy to not be considering, the cost of a HEPA filter, which is really simple, really cheap technology. And that's sort of the basic starting point. But obviously we'd like to see ventilation improved overall, and we'd like to see maybe sterilization, combinations of things, building up those layers, making things safer. We want sort of in hospital environments, if we're going back there, then we want to be looking at, maybe continuing with those virtual appointments and those virtual wards, and, phone calls to you waiting somewhere safer. So if you're in your car outside, that would have been sort of a safer option for us, because we can't choose about attending healthcare settings. It's an emergency sometimes. You just have to go in, and people are already cancelling their appointments. And you can see from my data there, 86% of the people that we surveyed said that they would or have delayed or cancelled medical appointments. And as I said earlier, this is a group of people who really need those appointments. And there are some appointments we really can't cancel. But yeah, we're worried about crowded waiting rooms and unmasked waiting areas. It's really worrying. And the second area that we're really concerned about, obviously, is education. I mean, you guys flag it regularly. If 1 in 5 children were infected 2 weeks ago, that's incredibly scary for our families. We're sending children into schools, into those unsafe environments, and we can't very easily avoid schooling, and there's no alternative. There's no remote learning that's been offered to our members.
Yeah, Lara, it's really good that you've raised that, because next week we're having a session all about that, completely devoted to that. So that's excellent. Can I just say, because we've got 2 other speakers, then we want to have time for the public to ask their questions too. I do hope you can stay on to the end, because there may be questions from the public that it'd be really helpful if you could answer. So many thanks. That was really informative and really helpful. And over to you again, Trish.
Right, yes. So one of the highest risk environments of all is transport. And the reason is because of the tiny spaces in say a taxi or a train or a bus, and also because public transport can be very crowded and sometimes underventilated. And as Lara has alluded, there's really not a lot you can do if that's the environment you're stuck with. There's not a lot you as an individual can do, except for making sure that you are wearing a really high quality respirator style mask. And you can see the little things printed on that mask, FFP2 or FFP3, even better, and KN95 or N95. These mean that the filtration in that mask reaches a very high standard. So wear one and make sure it fits you, because if there's gaps around the edges, of course, the air is going to get in. Now I'm going to introduce Lena Sirik, who's Associate Professor of Civil Engineering at University College London, and she does safe transport research. She's on holiday this week, but earlier on I did a pre-record and I asked her, what's the evidence that wearing a mask is going to help reduce COVID transmission on public transport? And I'm just going to show you a graph. And then before I play what she's had to say about it, I'm just going to talk you through her axes. So up the side is the number of COVID cases being diagnosed every day in the UK. And then along the bottom is time, and it runs from March 2021 through to January 2022. So about 10 months. And you can see at the beginning, there wasn't much COVID, and then there was a little blip in the summer. And then sort of end of November, beginning of December, this huge wave of COVID. And that's when they reintroduced the wearing of masks on public transport. So having explained what the graph's about, I'm now going to just play this 2-minute clip where Lena explains what they did and also what they found.
We took samples on 3 different lines, on the district line in April, May, in 2021, on the Jubilee line at the end of October, beginning of November last year, and then the Victoria line right at the end of November and into mid-December. So it was right at the beginning of this last set of sampling on the Victoria line that TfL mandated for masks to be worn again. And at this point, masks were not being worn when we were sampling on the Jubilee line. So from the data that we collected, only very few of our samples that we took on the district line earlier on in 2021 were positive for SARS-CoV-2 RNA. I think something about 30% of our samples in total, and all of them at very low concentrations. Then in October, November time on the Jubilee line, so at this point, you can see the numbers of cases in London have risen, but still below 5,000 new cases per day. And at this point, we found that quite a lot of our samples were positive, and this is both for surface and air samples, and they were significant amounts or concentrations of the RNA there. And then when we were sampling the Victoria line in December, so at this point you can see the numbers of cases are going up quite significantly. And on the last day that we were sampling, I think there were 26,000 new cases in the day. We found, again, that quite a few of our samples were positive, but this time to a much lower concentration of RNA. And at this point, remember, people were wearing masks, some because it was mandated by TfL, some because they wanted to save Christmas and not get ill before Christmas and be able to see their family. So our real finding here was that actually the wearing of masks really does make a difference, because when...
Okay, and then I stopped it there because she then went into a bit of a repeat. So let's move on from transport to buildings. And most of you probably know this already, but just to sort of provide a background to the discussion we're going to have, and people are going to be asking questions about this, there's basically 3 ways to improve air quality in buildings if we're talking about making it infection safe. The first, obviously, is ventilation, either natural ventilation by opening windows, and make sure you open more than one and get a through draft. Or in our public and commercial buildings, usually it's mechanical ventilation. You can't see it, but it's when the buildings get built, there's fans and things like the extractor fan in your bathroom, but a bit bigger and a bit more industrial scale. So those are the two ventilation methods. If you're using ventilation, the carbon dioxide levels are a reasonable proxy for how well you're doing with that ventilation. I'll come on to that in another slide. And another way you measure the quality of ventilation is something called the air changes per hour. And people are always asking, well, how many air changes should there be per hour? And the answer is, of course, it depends what you're doing in the room and how many of you are doing it. So there's no sort of magic number. You do have to get your building and the activities that you're doing in it properly assessed by someone who's an expert in building ventilation. The second way to improve air quality in buildings is to filter the air, filtration. And you may have heard the expression HEPA, high efficiency particulate air filter. Those are very good quality filters. They're the right size to filter out the SARS-CoV-2 particles. And they can either be portable, you sort of buy them and plug them in, or they can be built into the infrastructure of the building. So filtration, I'm sure, is something that's going to come up in our discussion, and it will be discussed in more detail next week in relation to schools. And the third way is ultraviolet light, which has been shown in a number of studies to kill the SARS-CoV-2 virus. And actually, you can buy HEPA filters, which also have an ultraviolet attachment. So you're actually attacking the virus in two ways. And you might also be able to ventilate as well. So just briefly, the carbon dioxide as a proxy of air quality. When you breathe out more carbon dioxide than there is in the air. And so lots of people in an enclosed space puffing away, you'll soon move from that dark green right up into the red. So get yourself a carbon dioxide monitor and try and keep within the green levels, certainly below 1,000 and ideally below about 700. So that's if you're using ventilation. Of course, if you're using filters, when it goes through the filter, it doesn't remove the carbon dioxide. So we're talking about a different kind of standard here. The filtration standard, in some building standards, they call it a MERV, which is minimum efficiency reporting values, but not all buildings use the MERV. But you can see at the top of this slide, MERV 1 isn't very good, and it doesn't filter out very much. In fact, it's almost useless. Once you get down to about MERV 8, the air filter will trap quite a lot of the bigger particles. But in general, if you're looking for an infection control standard, you want a MERV 13 or higher. And then if you go down, you can see where the HEPA filter sits. It's right up at MERV 17 or 18. So this is not my area of expertise. There's someone coming next week who knows more about it. But if people are talking MERV values and HEPA values, that's what it's all about. The idea is that the higher the MERV score or the HEPA score, the more of the nasty stuff gets filtered out. Let me just move on. So here's the two challenges we've got for building design. We've got a current challenge, which is that many of the buildings that we work and learn in are perhaps quite beautiful buildings, but they weren't designed with air quality in mind. Our buses and trains and cars perhaps weren't designed with that in mind. And so what we have to do is try and improve those existing spaces as well as we can, which is why people are buying those portable HEPA filters and throwing windows open and all that kind of thing. But there's also another challenge, which is a challenge oriented to the future, which is how can we design and invest in what's known as infection resilient spaces. And I'll talk about that in just a minute, but now I'm going to hand back to Susan, who's going to introduce our final guest.
Thank you very much, Trish. And welcome, David Tomlinson, who's from Fresh Air NHS. Now, when we go to hospitals or our GP surgery, we do expect to go there to improve our health, not to actually have our health made worse. And as we heard very eloquently earlier on from Lara, there are many people who are already vulnerable in relation to COVID and have to go to hospitals, GP surgeries, often fairly regularly. So you and the organisation you're part of have obviously got concerns about the quality of air and therefore the safety of the staff and patients who are in those buildings. Could you say something about what your concerns are?
Yeah, well, Fresh Air NHS is a kind of very small organisation of clinicians that got together over Twitter, actually. But we've got a shared purpose that's quite huge that you share as well, which is to fundamentally reshape the way we think about the way we live. And we've been living with clean food as a gimme. We've been living with clean water as a gimme. And the SARS pandemic, is a wake up that we need to think about air quality. This has actually been, to my shame, something I've been blind to for years. We've had seasonal flu, which every year has been affecting hundreds of thousands of people, killing thousands. And flu is an airborne virus that during the winter 2020 to 2021, there were 0 reported outbreaks in Public Health England's data, purely as a result of the combination of layered mitigations that you've heard about many times, but wearing face masks in public settings, especially in crowded indoor settings, is extremely important. So we've got an opportunity to recognise the fact that with SARS-2, there's a rather more virulent virus with a huge number of longer term impacts on the human body, which will massively increase the stress on health services if we let it run riot. So we get a huge amount of return on investment when we try and prevent disease. So we think in Fresh Air NHS that we should be trying to prevent SARS-2 transmission through encouraging systems change and encouraging behaviour change. So the system change we're looking for is better quality ventilation and attention to air filtration, just as Trish has explained. It's a huge topic, better left to engineers, but recognizing the airborne nature, the predominant airborne nature of SARS-2 transmissions, it's a virus transmission via inhalation, is key to achieving the motivation behind that change. And then the behavior change we're looking for is that we need frontline healthcare workers, incredibly valuable staff, to be given respirators to protect themselves. It seems like an extraordinary request when actually it's part of UK legislation for anyone facing an uncontrolled airborne biohazard to be given respirators. But nevertheless, 2.5 years down the line, we find ourselves in a really weird position of being blocked almost at every turn in our requests to initiate that change.
And can I ask why you think that is? Because many of us on this call also today have had an experience where you go into hospital or a healthcare setting with respirators, or what people call it a FFP2 or FFP3 mask, i.e. the well-fitting, good mask that is needed for Omicron, and even been asked to take them off and put these very flimsy little blue surgical masks that really aren't up to the job in the current situation. So what's going on there? It's really hard to understand what's going on.
It's mind-boggling, isn't it? So I think, in short, it's two things. So number one, I think there's too much of an emphasis on surface transmission and things that one touches being an infection risk. So when someone who's trying to do a good job at the front door, and I'm not wishing to appear down on any medical staff, but they're nursing staff, they're trying to do a good job, and they see someone in a mask and they think, oh, that might be dirty, so please change it to a clean one. So here's my respirator that I wear all the time, and I find it very hard to see how, according to physical laws, that becomes a dangerous surface transmission risk to anyone. Anyway, so they're trying to do a good job and are following rules, but sadly the rules were set in place at a time when there weren't enough respirators for medical staff. So there's a need to create a narrative that this was not an airborne transmitted virus at all, out of this scope of a small range of medical procedures that was perceived to be generating of aerosols, intubation being the highest risk one. So there's a narrative that you only had an inhalation transmission risk in a very narrow set of circumstances, don't worry, you're miles away from that. Here's a nice clean mask. By the way, here's your hand gel. So we've got to try and address the reasons why that narrative hasn't been allowed to change.
Absolutely. David, that's really interesting. And again, like Lara, I hope you can stay on till the end of the session, because there may be some questions for the public that you want to come in and address. Trish, back to you.
Great. Thanks, Susan. Thank you very much, David. So I thought we'd now briefly cover a report from the Royal Academy of Engineering, which was initially published last year in its brief form, but the final version came out just a couple of weeks ago on infection resilient environments. And the Royal Academy of Engineering said this: the COVID-19 crisis revealed flaws in the way in which we design, manage, and operate buildings that, if left unchecked, will disrupt management of this pandemic, but also other pandemics, impose high financial and health costs on society, and constrain our ability to address other challenges such as climate change. So this is really a clarion call to improve our buildings and how we run them. And I'm going to just highlight a few aspects of this report. And the first thing that they comment on is what I've called skills and capability. The staff working in buildings actually often don't understand the nature of transmission, the importance of air quality. At the moment, staff are not capable of taking steps to improve air quality. Some of them don't even want to open the windows, and they don't know where to get help and resources. So the Royal Academy say, look, we've really got to make sure that the staff at every level in our public and commercial buildings understand the importance of air quality and what to do about it. Secondly, there is a major research agenda. There's not enough funding being put into this research, but there's a lot of unanswered research questions. We need more evidence-informed building standards. People keep asking me, well, how many air changes per hour? What's the best kind of filter for this particular space? Although we've got quite a lot of evidence already, and that's embedded in the standards, we need more. We need to think about novel kinds of spaces and how to improve airflow through different spaces, especially now a lot of us have got open plan offices. We also need some behavioral science research on how the design of spaces influences human behavior. We need new technologies, and we need to look at all the different ways of infection transmission. For example, what about when someone goes to the toilet and flushes it? What might go up into the air, and how can we design the lavatories in our public buildings to make sure that that doesn't happen? It's quite a scary thought, isn't it? The next aspect of this report was a demand to improve regulation. Our regulatory bodies need to make sure that health and well-being are fully embedded in all building standards. It's not just energy efficiency, it's also the quality of the air that we're breathing in those buildings. And also that the regulators are able to develop and monitor those standards. And of course, if every building in the country needs to be looked at, there may well be a capacity problem there. Next, there's a few slightly conflicting goals. There's infection control, which is what we've been talking about. There's also thermal comfort. How many people in the last couple of years have thrown open a window at work and everyone said, look, I'm freezing cold, can you close the window again? And also energy efficiency. You know, with energy bills set to rise massively, how can we align these potentially conflicting goals? And again, that's probably a research question. Another thing highlighted in the report is that there needs to be particular support for those organisations who've got limited capability in this area. And they do point out that particularly small businesses, some schools and some services are really not yet at first base with any of the things that we've been talking about today. And finally, they highlight rather more positively that we need to learn from real cases. We need to look very carefully and in a very detailed way at examples of what good looks like. There are buildings that have been beautifully designed, and they managed to tick all these boxes, and they're working well. And we need to find out not just what they're doing now, but how they got there, and which things got prioritized. And the way we need to do that is to actually explore real cases. So lots and lots of things to learn from that report, which you can Google and download. Finally, I want to just encourage you to, again, this is something you can Google, IndySage Scores on the Doors report. This came out, I think, in October 21, where one of the problems when you go into a room is you really don't know how good it is. But, you know, if you could, if one could go in there and assess all the different aspects of air quality that we've been talking about in this session, and also identify the different behavioral mitigations, you know, how many people should be allowed in that room for how long before there's a break, and how should the furniture be arranged, all that kind of thing. It would be theoretically possible to put some kind of label on the outside of that door so that you've got some idea, particularly if you're a clinically vulnerable person, but even if you're not, do I want to go in that room? So do look up that report. And that is now the end of my presentation, and I will hand back to the chair, who's going to, I think, give us some questions.
Goody, back to you.
Have we lost Goody?
Goody, you're on mute.
Can you hear me now?
Yeah.
Oh, I'm so sorry about that. I was just saying thank you so much for such a fascinating presentation and for the panel's expertise there. I've learned a lot from what we've just heard. And I have to say that for me, there were some really interesting take-home messages that came out of this, which is this ongoing discussion we've had throughout the pandemic about the onus that's being put on the individual to have to make decisions about risk, in relation to all of the other issues that are going on out there, in contrast to what we should be making as social decisions, together as a culture. And what time and time again we've heard from all of you about how the evidence is there. We know how to prevent this. Masks work, ventilation works, and this is all cheap and it's all available. And so the question becomes, how do we implement this in a society and a culture which seems resistant to almost our collective health together? And so it will be interesting to see in the questions that kind of concern raised, but also this other concern about regulation and how do we make sure that this goes as we move forward. We know this is not the last pandemic. How do we make sure that we can keep each other safe in the future? So let's move forward now in our discussion to the public questions. And we actually have our first question from someone called Louise, who I think is joining us today. Louise, what's your question, please?
Hello. Thank you for having me on. So it's interesting listening. We're, as a family, being quite careful to avoid COVID. We understand that as few infections as possible is a really good idea. And I think we've become pretty good at risk assessing and sort of adapting as necessary, really. Thank you very much for the information from Independent Sage, because that's made that a lot easier for us, and we've learned a lot in the last couple of years. One area that we do feel very exposed in, and we find it quite hard to mitigate, is school. And I think that's going to get even harder this year, because we've got a 9 and 11-year-old. They've been in a large primary, and from September we'll have one there and one at secondary. So we've tried our best. We've done things like in the past, when there's been really high levels of COVID in school, which unfortunately has happened quite a few times, we've taken them out, or we've used masks, although I have to say it's quite hard to find well-fitting, good quality masks for children compared to adults. And it's also quite hard for them to wear them in school when they're the only ones, and teachers can be a little bit resistant to them, if I'm honest. With comments like, oh, you must be hot and I can't hear you, you'll need to take it off. So that has been tricky. So we're doing things like taking them out at lunchtime, requesting open windows. We offered HEPA filters, they were turned down. So it feels a really difficult place to mitigate. And it's become, I'm sure you're well aware, and probably we'll cover next week, but it's really hard to get any information now as well. So again, they've just had a big outbreak at school before the summer, but you only know what you find out through the kids, really. So what advice can you give for families who are sort of trying as best they can everywhere, but obviously really have to put the children in school for education and socialisation?
Thank you, Louise. I mean, that question hits the nail on the head, doesn't it? And as we said, we're going to be talking about safe schools next week, so I'm sure you'll get more information then. However, what you're talking about is basically about behaviour and how do we, again, look after each other collectively in these spaces. I have a feeling that Professor Susan Michie will have something to say on behaviour here, but actually this is open to all of us because we've all had to engage in this discussion and think about how do we keep each other safe in various contexts. Susan, do you want to maybe start and then I'll see if anyone else wants to chip in?
Sure. Well, I think that, Goody, what you were saying earlier is so important to try and get as many people amongst the parents who are thinking along similar lines and collectively try and approach the head teacher or a group of teachers together to discuss the issues, because often teachers may be very overwhelmed with their own tasks and not really have the space to really pay attention. Similarly with the school as a whole system. The other thing to think about is, are there parents who are on the governing body of the school, parent reps that you could talk to and get them to raise it there? So I think just think about all the ways in which schools can be influenced. Basically, there is such a thing as parent power when you get together. I know from my own experience, my children were young, we got significant changes, very different kind. You've got, the teachers, but also the non-teaching staff who are, often really good allies. And then there's the governing body. So maybe just think strategically, and probably, Louise, you've tried all those things. But that's my initial thoughts of what you should do. But it sounds like you've been doing so many of the right things anyway, and it's a very frustrating situation to be in.
Thank you.
Professor Anthony Costello, you put your hand up.
Yeah, I mean, what you're facing is ridiculous, but it's part of a whole move in this country and other Western countries to ignore what Goody was saying, the elements of community mobilization, social interventions, and a sense that there is a community and a population that needs to be protected, not just individuals. And it started from the very beginning of this pandemic with the whole herd immunity stuff. Even in the early parts of February 2020, they were saying it's inevitable, this is going to spread, there's nothing we can do about it. And that has carried on, and the politicians have also bought into all of that. And there's a real anti-public health movement in this country, which has just got worse really over the past 20 years. And there is also within the medical profession a total dominance of biomedicine and biomedical research. Now, most biomedical research is great. I'm not knocking that. But, when you find that 94% of all medical research funds go into biomedicine and only 2% goes into public health, you've got an idea of the sort of cultural problem that we face in all our institutions. So, I mean, I could wax lyrical about this, but you're the victim of this, and we're all the victims of it. And it's going to take because I don't think we're any better off now than we were 2.5 years ago. And if another pandemic hits, we're in deep trouble.
Thank you, Anthony. Dr. Stephen Griffin.
Thanks, Kitty. I completely endorse everything everyone's just said, but one really important thing that we can do is ensure that we get our children vaccinated. There's been such a poor uptake of childhood vaccines, mainly because of mixed messaging, I feel, from the government and elsewhere, and a lot of scaremongering around that. But really, if you want to reduce the level of risk from your children catching COVID, or indeed potentially getting long COVID, we assume based on adult data that will help. So please get children immunized. And come the autumn, when we're likely to see another wave of SARS-CoV-2, we're almost likely to get that coincident with influenza. So please get flu vaccines as well.
Thank you, Steve. That's really well said. And given that Christina told us about the 20%, almost 20% absence of students right now with this, it couldn't have come at a better time, that message. I'm going to shift us on. Louise, thank you so much for such a wonderful question and getting us started. The next question comes from someone called Sylvie, and I'm going to read this question out for her. She says, I'm being forced to go back into the office 2 days a week. Apparently, 7 people in the office have just tested positive in the last week alone. I plan to wear a mask, but no one else will be. I'm going to be taking in a HEPA filter too. Hopefully, I don't get pushback on this. Ventilation is poor as it's an old building. But the biggest problem is that no one else cares. So I fear I'm going to get resistance to trying to put mitigations in place. So my question is there anything more that I can do to try and protect myself? And do the panel have any general advice on how to engage with employers to put mitigations in? Thanks. This touches on a lot of the questions that Louise raised, but here we're talking about the employee-employer relationship, which I think is slightly different. What does the panel have to say to this, I wonder?
Well,
okay, Susan, kick us off again.
Yeah, I mean, I think the first thing is do they really not care? You know, and why don't they care if they don't care? You know, it really may be that they don't have enough understanding of how this is being spread within the office environment and how it can be so dangerous for some people. I mean, this is one of the things, it's a huge variation. For some people, it is no more than a heavy cold or even less, but for other people, it's devastating for their lives. So I think one of the things is to get a discussion going. It's a bit like before, you know, how can she get a discussion going at staff, with the staff, the other people who are employed there? Can she talk to the employer about getting a group together, having maybe a speaker come in, raise awareness, you know, in the first place, but also combine that with this is what you can do about it. There's no point making people feel worried about things without being very clear that there are easy, feasible things that can be done about it. So I think that, you know, thinking about all the things that could be done, and, you know, rather than expecting everybody to wear masks when they're not signed up to it at the beginning, maybe go for the HEPA filters and you know, really try and get the staff to do that on the basis that even if it protects 1 or 2 vulnerable people, because we don't, until you get it, you don't know how vulnerable you are. And you don't know how vulnerable you are, even if you've had it once or twice, how vulnerable you are the next time. So I think, you know, don't give up. Don't assume that people don't care or won't care, but try and get discussion going and try and think of things that are feasible and get people to think about the collective, not just themselves.
Thank you, Susan. That's really well said. Of course, this also comes back to a question, again, of culture and the culture of unions. And, you know, what protection do we all have at work? You know, Susan, you're right. The question to ask is, do they care? But let's presume that they maybe they do. How do you still take this to your employer? Now, Steve, did you have something that you wanted to say about unions at all? No.
Yeah, I thought maybe Aris might comment as well, because he's more involved with that sort of thing. But just to remind everybody that there's this thing called the COVID Pledge, which many unions and other establishments such as the BMA and various other, including the Clinically Vulnerable Families, and everyone has signed up to, and that's asking employment establishments to ensure that people can have access to, you know, MPIs and reasonable time off work, and supported not to come in when they're not well, for example. And I think that's the sort of place where we can start, but you risk escalating things, and it's really difficult. But I think, yeah, I think Susan's absolutely right. Make sure that people are caring first.
And I just wonder whether this actually relates to what David Tomlinson was talking about, you know, in terms of you having to try and ask for things like respirator masks. You've obviously had this discussion with employers before. I mean, is there any advice you could give Sylvie here in regards to that? How do we go about trying to tackle this?
I think what Susan said is perfect, in that you need to understand where your employer is, don't you? Because something I'm really bad at is starting from a standpoint of not feeling like it's always going to be a fight. So sometimes one would actually have someone who's recognizing that it's quite nice to keep their workforce healthy, and a profitable business with healthy employees is quite a good business. So, you know, it's really, I find it incredibly hard through the 2.5 years I've been through to realize that you could be pushing on an open door. And what would be really, really useful, I just thought this a minute ago, but, you know, not wishing to impose on anyone, but if there's an information sheet, a crazy information sheet for why one might like to prevent transmission of SARS-2, that can be used by anyone that's struggling with young family to find the time to pull together scientific resources, with, you know, who's an employee just wanting to give something to their boss. I mean, I've prepared a few things for school and work and so on over the years, over the months, but it would be an incredibly valuable resource if someone could give their employer a trusted resource and say, look, have you seen this? We can prevent this, and it will be really helpful. You've just had 7 staff go off sick. How about we try and prevent that?
Brilliant. Thank you, David. Now, I saw that Lara's hand also shot up there. Lara, did you have something to feed into to this?
Yeah, just a little bit more really. So for us, I mean, the COVID pledge is fantastic, but it's kind of our minimum requirement. You know, we really do expect employers to be looking after their staff better. And just a little bit on vulnerable people, it might be that, you know, you can ask for a personal risk assessment based on your individual risk. It might be that your employer can offer work from home. And we really should be pushing for people who are symptomatic. If they're not testing, they should be working from home if they can. They should not be in the office. You know, they shouldn't be spreading the flu. They shouldn't be spreading all sorts of bugs. We should start to think differently. And if that's available, you know, we should consider that. And maybe looking at flexible hours for working. You know, if people leave for work at different times, then the rush hour is more spread and then the risk is spread. So we'd like to see things like that.
Lovely, thank you, Lara. Professor Martin McKee, can you quickly give your comments, because we're going to have to wrap up soon, I'm afraid.
Yeah, sure. And, you know, this is really quite amazing because this country is facing a huge labour force shortage, and we see it in the health service, we see it in the travel industry, we see it in hospitality. And if one reads newspapers like the Financial Times, they're really highlighting how this is a crisis for employers. I think employers get this. And many of them are looking at ways in which they can work together with unions and with others to try to do something about it. So we need to get that dialogue going. But this, and I'll just do a quick plug, because about half an hour ago, we published something in the British Medical Journal, which is online, which makes exactly this point.
Brilliant, thank you. And yeah, your plug is welcome here. So I'm afraid that this really is all we have time for today. And so let me just thank, first of all, the guests who joined us, and also our guests who sent in their contribution ahead of time. Thank you always to the members of the public who support us and who send in their questions. And of course, to all of our panelists who join us week after week, providing us with invaluable information and expertise. Now, remember, there's more to be said on this particular topic, and we're talking about safe schools again next week. So we'll be back, same time, same place. In the meantime, please stay safe.
Thanks all. Bye.